I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question. This is a hearing about the government licensing the electrocution of people to cause grand mal seizures.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
Yes, Michael Allen from Dallas, Fort Worth area. I think it's interesting the anti-ECT people have had their say about this composition of the panel, etc. I would like to say I can't think of any other medical issue that would cause this much brouhaha other than perhaps a consensus panel on mastectomy in women or hysterectomy electively done. But with that comment aside, I would like to make a comment and a question about the efficacy studies. The efficacy of ECT in severe depression has never been questioned previously to now, when we have all this introduction of brief pulse unilateral ECT, when in fact studies are now being done like Lambert-Gills to show that brief pulse unilateral treatment, when limited to 6 treatments, may be no better than placebo. What I would like to ask Dr. Brandon is, how about the North Park study and some of the other studies that found negative results, i.e. the ECT is no more effective than placebo? Was the common British practice of unilateral brief pulse non-dominant ECT the standard against which failure or success was measured?
And also that very quickly, so the only study which included unilateral was the Lambourne and Gill, which failed to show a difference. The North Park study did in fact show superiority from ECT, but the authors have been rather reluctant to draw the evident conclusions from that, and to commented on other aspects of it.
Okay, I'm Rich Weiner from Durham, North Carolina. Since almost all the surveys that have been done recently have indicated that the great majority of ECT is being given in drug-refractory patients regardless of diagnosis, it might be important to focus more on this issue. And I'd just like to point out one study that I don't think was mentioned, and that's Avery and Lubrano's 1979 publication, the 1964 Italian study, Di Carolis et al., which specifically looked at the issue of effectiveness of ECT in drug-refractory depressed patients. And this study is also notable because it included literally hundreds of patients, probably the largest comparative ECT study that was ever done. And this study showed that of the patients who did not respond to an index course of treatment for 4 weeks of high-dose imipramine, that the percent that responded to ECT, I believe, was close to 80% of these drug-refractory patients. And I think this is an important consideration to keep in mind, given the utilization that's actually being carried out of ECT in clinical practice.
Dr. Breggin again. I want to, with some embarrassment, say that when I was invited, the only one of 12 physicians in this conference who was against electroshock, that I was told I had an opportunity to respond each time to the various statements that were made. I didn't know the most of you, and that I have to race up to the front and stand in line and have 2 minutes to respond, because I am of the 12 or 13 physicians here today, the only one who is against electroshock treatment. So I feel a great burden on myself, and at the time it seemed good either. I feel a great burden on my shoulders to communicate. What we have established so far, just in this brief interchange, is that there are basically no studies to support the claim that electroshock prevents suicide. The second Avery study that was brought up shows at 1 year or whatever the end follow-up, no difference. The second one we mentioned, no difference between patients who are untreated and patients who got electroshock. The only difference was that if you got drugs, you had a higher suicide rate. And you know, it isn't easy to have all this in your head, to be standing up and be trying to get it out in 2 minutes. So what I want to come back to with you is that faced with the challenge, none of the doctors who support ECT have come up with any studies. All they can mention is 2 by Avery and Winokur, and the first one goes by the boards, and the second one also goes by the boards. I'd also like to take a minute or two and comment on the general issue of the efficacy of the treatment and to show you the kinds of things which if I had an equal time, well, we had another psychiatrist here, I'm not the only one to speak, the kinds of issues that might have come up. The most quoted study today to show the efficacy of ECT is the British Commission study. It's been variously referred to as MRC and other things. You would think it would be important to know that in that study, the efficacy for ECT was only found for women. And that of all of the men, there is no statistical efficacy shown. Nor is that even mentioned in the summary of the commission. One must spend one's hours reading the actual data because the summary is presented exactly today as Dr. Foster and Dr. Brandon presented it, as if it's a study that just clearly demonstrates the efficacy of ECT. Why women respond better to ECT than men, I think I can explain to you later on in terms of the brain damaging hypothesis and what our norms are for women versus men.
I'd like to Dr. Brandon could respond to that interpretation or comment about the study, if I may.
Well, when I'm done, am I 2 minutes up?
Yes.
Many times over.
I'll end at that point, and again with a facetious remark. I am the only one of 13 physicians invited here who is not in favor of ECT.
I can't comment on the MRC Northern Park study. I haven't analysed the data separately for women. I have, however, analysed it separately for women and men in the Leicester study. And that shows equal efficacy of both sexes.
Harold Stackline from the New York State Psychiatric Institute. First, a question to Dr. Brandon, and then a question for Dr. Small. Dr. Brandon, in looking over the sham real ECT studies, you referred to them throughout as placebo real ECT studies, and I wonder about that a bit. One, it seems that the variability that is seen in response rates to the study is actually very narrow for the ECT groups. That the percentage of reduction of depressive symptomatology seems to be very consistent across the studies, regardless of the centers, with one exception. But that there's marked variability in how well the sham patients are doing from study to study. I mean, in some study sham patients simply don't seem to do well, and others there's a considerable antidepressant response to sham. And I'm wondering whether that reflects what we would first think of, which would be sample differences, the percentage of patients who are resistant to medications who were entered into the study, or in fact whether that reflects differences in sham procedures, in fact that anesthesia could be an active medication. So that's one question. And the comment is, in terms of the data that were presented on mania, just like I had that, we recently completed a pilot study prior to the random assignment trial to intensive psychopharmacology or for ECT in medication-resistant manics. I think that's a very important term. These are manic patients who are acutely psychotic who have failed on active medication. In our pilot study, we had approximately an 80% response rate in medication-resistant manics to ECT.
Dr. Brandon, can you respond to that?
Most of the studies did in fact show the high end of the placebo response rate. And it's difficult to avoid the conclusion that the procedures themselves play some part in elaborating the placebo response. So far as I'm aware, none of the patients selected treatment-resistant cases. I did have some suspicion that some of the MRC and Breggin-Audience cases from outside the catchment area may be. Secondly, in the rest of the study, I suspect that, well, I can tell you that a substantial proportion of the placebo that had an ECT group had already had a course, an adequate course of antidepressants before they had the ECT. There was no difference in the placebo response on whether or not an adequate course of USC.
I'm afraid that we are running already 5 minutes late for the lunch break. We'll apologize to those who can stand in line over here. We'll be reconvening at 1:15 this afternoon. Thank you very much.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices, cited the literature as whether it's signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320 some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer I used to hit a nail. But I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but thank you for your point. I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got
All right, out with your gum. Out with your gum.
Okay, this won't hurt. It'll be over in just a moment. What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well.
Now just bite down on it.
Oh.
That's right. Just bite down. Now bite down on it.
Good. Are you ready?
Ready.